So first, some objectives. We'll talk a little bit about some relevant ocular anatomy, how contacts sit on the eye and where they sit. We'll talk about some patients that would be good candidates for contact lenses and some patients that maybe should not wear contact lenses. However, with current lens technology, there are very few patients that can't wear contact lenses anymore. The hurdle these days is really just, can they get them in or not? We'll talk about some ophthalmic conditions that can be treated with specialty or medically necessary contact lenses. And then we'll talk about some systemic conditions, how they can affect the eye, and then how can we treat that with medically necessary contact lenses. So first, I guess let's just talk about what is a medically necessary contact lens. So these lenses address specific eye conditions where glasses cannot. So it's not just that you don't want to wear glasses, you prefer to wear contacts, it's that you need contacts to treat a specific condition. And there are a number of conditions that fall in that realm. But it is purposely a bit of a vague definition because a lot of things fall in that category. Insurance carriers create their own definitions, which is frustrating, but they have different cutoffs for vision. So they may say, okay, if you can see, 20/60 with glasses, we consider that good enough. And to give you a reference, like 20/40 is the cutoff for a driver's license. So many insurances consider, even if your vision's not good enough to drive, they still think that's good enough. And then the even more frustrating thing is, even if you do fall under their criteria, often they don't cover or pay for the lenses. So that is definitely a hurdle that we're always fighting. And the cost of these lenses is very variable. The lenses we'll talk about today, average cost is probably around $700 per lens. So $1,500 roughly for both eyes. They can get much cheaper, they can get much more expensive, but that's the average cost. And it is frustrating when insurances won't cover that, since these lenses can, very significantly improve vision, very significantly improve quality of life. One of the first patients that I saw here at Georgetown, so yeah, like 12, 13 years ago now, I guess, she was a young woman, actually early 30s, and she was on disability because she was functionally blind. She could barely see her hand in front of her face. She was just sort of seeing colored blobs all the time. She couldn't read, she couldn't drive, she couldn't work. She lived at home, was dependent on her family. She had tried, a number of different glasses and contact lenses over the years. They just wouldn't stay on her eye. She had a condition called keratoconus, which we'll talk about later, but her cornea was just very steep. And so anytime she put a contact lens on, it just popped out and fell off. And then she eventually, made her way to Georgetown. She was fit with scleral lenses, which we'll talk about in this lecture. And, she could instantly go from, seeing blobs in front of her face to 20/20 vision. And literally within a month of getting the lenses, she moved out of her parents' house, she got her driver's license, she got a new job, she moved to a new state, and I never saw her again. One of my greatest success stories. No, actually, she did fly back the following year, and she was doing great. And these lenses can be life-changing for patients. Okay, so some anatomy here. So this is sort of slice of the eye. Contact lenses are going to sit on the front surface here, the cornea. This is the anterior chamber behind the cornea. This is the iris with the opening, the pupil. And that part's going to be important, actually, because some of these medically necessary contact lenses can be used to reduce light sensitivity. So if your pupil is not functioning correctly, you'll be letting in too much light. The lens is behind here, and that's attached by zonules to the ciliary muscle. That part's also important because over time, your lens gets less flexible. Normally, when we look at something up close, your lens changes shape to add more power. You need more power when you're looking at something up close. Generally, in your 40s or so, your lens gets less flexible, and so you lose that ability to focus up close. So there are contact lenses that can help with that specifically. And then eventually into your 60s, that lens also becomes cloudy. That's a cataract, and at that point, contacts don't help that much. Just to finish out the anatomy here, this back layer is the retina. This pink layer is the choroid. That's a layer of mostly blood vessels. And then the gray layer is the sclera, so that wraps around to the front. So most contact lenses sit on the cornea, but scleral contact lenses are going to sit over here on the sclera, and then they actually completely vault over the cornea. So they're just sitting on the sclera only. They're not touching the cornea. And our cornea is very densely innervated. So when something's sitting on your cornea, you feel it. When something is sitting on your sclera, you don't feel it as much. So scleral lenses generally are very comfortable. And then this is, of course, the optic nerve that then connects the eye to the brain. So One important part of the anatomy is actually the tear layer, because contact lenses are going to be sandwiching a layer of tears between the contact lens and the cornea. And so the tear film has three layers. There's a mucus layer that keeps the tears stuck to the eye. That's produced by goblet cells in the conjunctiva. Then there's an aqueous watery layer, so that's sort of like the bulk of the tears. And then there's a lipid oil layer on top. That's produced by the meibomian glands in the eyelids. And so, dry eye can be caused by a number of different things, and often a combination of things, but sometimes you don't make enough tears. Sometimes you make enough tears, they just don't stay on your eye. They either drain out quickly or they evaporate quickly. So that would be called evaporative dry eye, and that's usually caused by a deficiency in the oil layer of your tears. So we'll talk about that a little bit more, because contacts can help keep tears on the eye too. Okay, a little bit of optics here. So this eye here, this is a myopic eye. So this is a nearsighted eye. So when light comes in, it's getting focused by a few things. It's getting focused by that tear film first, actually. So if you don't have a good thick tear film, if you have dry eye with dry spots, you're going to have blurry vision, because the tear film is actually the first part that light hits. So if you ever have fluctuating vision, if you look at something and you have to blink a few times to make it clear, that's a symptom of dryness. Even if your eyes don't feel dry, that fluctuating vision is dryness. So it hits the tear layer, it hits the cornea, and then it hits the lens, and all those things focus the light. And ideally, that focal point of light would be hitting the retina directly, exactly on the retina. If you think of your eye like a camera, the retina is the film. So we want that focal point to be right on the retina. If it's too far in front or too far behind, then your vision is blurry. So myopia is nearsighted. That's where your eye is actually essentially too powerful. So it focuses the light, but just in front of the retina. So myopic patients are going to have a negative prescription, a minus prescription that's going to take away some of that extra power. Presbyopia is the opposite scenario. This is where your eye is too weak. And presbyopia is specifically when your eye becomes weaker over time from age. So 40s, 50s, 60s. The lens gets less flexible, so the lens is not as curved and is not able to add that extra power. So your eye is still focusing the light, just not quick enough. It's too weak, so the focal point is behind the retina. So that patient is going to need a plus prescription. So you can get over-the-counter reading glasses and plus prescriptions to sort of help with that. And then we'll talk about contacts to help with that. Okay, and then this is a picture of how the lens would flex. So this is an unaccommodated lens. When the ciliary muscle is relaxed, the zonules are pulling the lens tight, flat. And then when the ciliary muscle contracts, the zonules loosen, and then the lens bulges forward. So we lose that flexibility to bulge forward and become more curved over time. Okay, so let's talk a little bit about the contact lens fitting process. So we always start with the comprehensive eye exam. We just, kind of do the general eye exam, but there are special testing that we need to do for contact lenses specifically. So sometimes patients, come through and they just ask for, right when they're walking out the door, they have their glasses prescription and they ask, oh, by the way, can I have a contacts prescription as well? Unfortunately, it's not that simple. There are several key differences. One is the power is prescription is often different for contact lenses, since it sits on your eye directly versus out a few millimeters. And then two, we have to specify all the parameters of the contact lens. So the material is a key one, the diameter, the curve of the contact, and it depends how big the contact is. Sometimes there's just one curve, sometimes there's a secondary or tertiary curve as we get further and further out in a large lens. So these are some of the tests that we do to find those parameters. Corneal topography is an elevation map of the cornea, so it shows how steep the cornea is, and then we try to find a curve that matches that corneal curve. Refraction is the process of finding the patient's prescription optically. So how much power do we need to either add or subtract to get that focal point right on the retina? So lamp exam is a high-powered magnifier. We look at under bright light with fluorescein dye. Sodium fluorescein dye is a yellow dye that we put that colors the patient's tears. And so we can see the tear film in much better resolution with this dye. We can also see where does that dye settle. So if there are dry spots, that dye will settle into those areas. An anterior OCT is a scan of the front surface of the eye, the cornea. OCT stands for optical coherence tomography. You can do posterior OCTs also for retina and optic nerve, but for contacts, we do anterior OCTs. And then we check the eyelids. The eyelids actually are quite a bit of a factor in contact lenses. Some of the lenses we'll talk about today have multiple powers in the lens. And so when you first put a contact in, it could have been in any orientation. And so part of that, it rotates into the right spot a little bit from gravity, but the lenses have thick zones and thin zones, and they require good eyelid anatomy to push the lens into the right spot. So if you have like a floppy eyelid, for example, or Bell's palsy, for example, sometimes these lenses don't work. And then we talk to patients about, what they need to do to be able to wear lenses. So they have to be able to put them in and take them out, or maybe a caregiver could be doing that. But we need to make sure that they can actually do that. And so the first time they get lenses, we sit with them in the office to make sure that they're able to do that. Very specifically, we need to make sure that they can take them out. Sometimes, in the office, it's a, artificial environment, patients are nervous, someone's, staring at them. They can take the lenses home to practice putting them in, but taking them out, we need to be able to see that they can do it. So otherwise they'll get home and potentially sleep in the lens if they can't get it out. We'll talk about how to clean and disinfect the lens. Almost all the lenses that we talk about today, you cannot sleep in. So they do have to take them out at night, clean them, store them in a disinfection solution, and then, put them in the next day. And then we'll talk about disposal. So some of these lenses you can dispose of just like a typical contact lens. You replace, potentially every day or every 2 weeks or every month, you throw it away and put in a new one. But most of the lenses we'll talk about today are custom lenses. Custom lenses generally last a lot longer, 1 to 2 years before you have to replace them. Usually your eye itself or your prescription is changing before you need to replace the lens. There are a few contraindications, mostly just being concerned about infection risk. So if you have good hygiene, wash your hands before you take out the contacts, the infection risk is pretty low, but it is higher for someone that's immunocompromised. There's a significant risk with getting water on these lenses. New lenses let in a lot of oxygen, which is great, healthy for the eyes, but they also can let water in. Water is not sterile. So you have to be careful with swimming, beaches, lakes, hot tubs, even showering is generally not a good idea, especially with some of these custom lenses. Wearing schedule is how long the patient should wear them. So ideal wear time on most of these lenses we'll talk about is 12 hours. So you put it in at 8 a.m., you take it out at 8 p.m. Most people's days don't end at 8 p.m., unfortunately. So people tend to wear these lenses longer than they should. And again, these are medically necessary lenses. So it's not like they can just take out their lenses and wear glasses. Glasses don't work for them. So patients often do sort of push the ideal wear schedule here, which increases infection risk. And then there is a consideration about environmental factors. You don't want to wear them in like a very dirty or dusty outside environment. We generally do a diagnostic lens fitting. So we have trial lenses in some different sizes, and we put that on the patient's eye to see what size would fit them best. With the newer scan technology, we can get a pretty good idea of what lens should fit in terms of diameter and base curve. But once it gets on the patient's eye, there's some compression of the lens from the eyelid pressure, the corneal thickness, the tear layer. And so sometimes once we get the lens on the eye, we need to adjust something. And then we measure what power we need once the lens is on the eye. Then we order it. Some lenses you can just order from anywhere. So the custom lenses have to be specifically made for the patient, and the average time for manufacturing is about 10 days. Then they'll come back, wear it for a little while, take it home, and then a follow-up 2 weeks later. Ideally, at that follow-up, they would have put the lens on earlier in the day so that we can see what does the lens look like once it's settled. Is there still an adequate tear layer? Is the lens rubbing on any area? And that's where we use the dye to help us see that. And then there's ongoing follow-up care, and we have to continue to monitor to make sure the lens is still fitting. If the lens is too loose, the patient will know that usually. It's going to feel uncomfortable. It'll feel like it's floating around a little bit. If it's too tight, that's the tricky part. They're not going to necessarily know that. They'll feel okay. Their vision will be okay, but they won't be getting enough oxygen to the eye, which long-term will cause its own complications. Okay, so these are some of the instruments that we're using. These top two we use to find the prescription. This is called a phoropter, which just has many different lenses in it. This is a retinoscope, which is a light that we shine usually through the phoropter, but you could shine the light through just loose lenses that you're holding. And then we change the lenses, adding or subtracting power to get that light focused exactly on the retina. So this gives a very good estimate of the prescription. And this is, for example, how we do prescriptions on babies that can't give any input. You can get a very accurate measurement just based on that. This is a topography down here. So this scale here is the steepness. So red is very steep. Purple would be very flat. So if you think of this like a mountain topography, red would be a peak and then purple would be a valley. So this is an average cornea. Everything is in the greenish area. And then we'll look at some not average ones. And then this is an anterior OCT. So here's the cornea, here's the iris, the opening is the pupil, and then there's the lens. This is a SLAMP exam photo with fluorescein dye. So we use fluorescein dye and then a blue light filter, which causes the dye to stand out. And so this is an even tear layer, and then these are dry spots here. So this is where the dye has evaporated. So this is a specific test called tear breakup time. The patient blinks, we look at the tear layer, and then we tell them not to blink. And we count how many seconds does it take before we see these dry spots show up. So average time is 10 seconds. Anything under 6 is considered dry. These are some eyelid evaluations. You can see all the irritation here. This is a condition called giant papillary conjunctivitis. This is essentially an allergic reaction to the contact lens material. So if a patient has this, it's treated with topical antihistamines. And then after that, it's resolved, we have to either have them wear the contacts much less hours per day, or we would try to switch them to a different material that wouldn't be as irritating. And then this is an imaging of the meibomian glands. So in this one, you can see the meibomian glands running through. There's some clogged glands here, and then these are severely clogged glands. So in these pictures here, the patient is not going to be producing that oil layer of the tears. So even if they're making enough tears, the tears aren't going to just stay on the eye. They're going to evaporate very quickly.
The bottom, is there any, is that a special light or is that just look and see?
This is a special light. Yeah, this is a special camera, an infrared camera that takes these images. Yeah. Okay, so now let's talk about some lenses. So the first category of lenses are just for patients with very high prescriptions. So, you know, we looked at some of these instruments here. Most of these instruments, including a lot of the automated instruments, they go up to a prescription of about a -20. The patient, the young woman I talked about before, she had a prescription of a -35. So once you get past, you know, what you can do with instruments, you have to use loose lenses and stack multiple lenses together to try to get the right prescription. And you can theoretically get very high glasses prescriptions, but the glasses are going to be very, very heavy, very thick, uncomfortable. They're going to have a lot of distortion around the edges of the lens. And specifically with minus prescriptions for myopia, you get a lot of this minification. So this like shrinkage look here, and that's going to cause distortion. So we can get custom contact lenses. Most like just an average contact lens that you would get at any store goes up to about a 12. And then, you know, much beyond that, you would have to have a custom specialty contact lens. Hyperopia is the opposite case where your eye is too weak. Earlier, we talked about presbyopia. That's also your eye is too weak, but specifically from age. Hyperopia is just your eye was always too weak. So that's going to have a plus prescription. You need extra power. But the other case that causes very high hyperopia is aphakia. So aphakia is when you had your natural lens removed. So for example, you had a congenital cataract. The cataract was removed, but the baby infant was too young to put in a lens implant. So they lost that natural lens, which itself is about a +15. So now they're going to need +15 to +20 in glasses. And you can theoretically do that, but you're going to, again, have those same problems, very thick lens, distortion, uncomfortable. And so that's where a custom contact lens can really help those patients. Almost everyone with aphakia wears a contact lens, and you can do contact lenses for infants, and there are a few that you can sleep in up to 30 days at a time. Okay, multifocal correction. So this is getting contacts with 2 powers now. So eventually with presbyopia, you lose your ability to focus up close. So then you are going to split into 2 prescriptions, one prescription for far away, another prescription for up close. So it's not as difficult in glasses because bifocal glasses, you can choose where you look, right? You look through the top for the distance power, you look through the bottom for the reading power. In a contact lens, that becomes much more complicated because you're looking through all the powers at the same time. And so a multifocal lens, generally, there are some different lens designs, but generally they are designed like this with custom concentric rings. So you'll have a distance ring, an intermediate ring, which would be like a computer distance, and then a peripheral ring. For near or distance, you can decide which one is in the center. And so you are looking through all the powers at the same time, though. So your brain has to adjust and decide, okay, I should use the distance power if I'm looking at something far away, and vice versa if I'm looking at something at reading. So there is an adaptation time, and some patients do really well with that. Some patients don't. Usually we tell them to wear it for about 2 weeks and see how they do. If the distance is not good, then we can, adjust the power and make the distance stronger, but it's going to come at the expense of reading. The stronger you make one power, the harder it is going to be to ignore for the other. If everything is not good, distance and reading is both not good, then, they may just not be able to adapt. And probably about 10 or 15% of people can't adapt to these, but most people can. Okay, astigmatism. Astigmatism just means that your eye is not spherical. So most people have some level of astigmatism. You may have heard of an analogy like a basketball or football shaped eye. I usually describe it more like a ping pong ball. That would be a perfectly spherical eye. And then an egg would be an aspherical eye with astigmatism. So regular astigmatism is that egg. It is oval shaped, but it's symmetrical. There's a one direction curve in the vertical direction and a curve in the horizontal direction. Irregular astigmatism is an oval-shaped eye, but multiple peaks and valleys, different areas where they're steeper, different areas that are flatter. So it's essentially like a bulge in a random area. So that is very difficult to correct with glasses, because if you have regular astigmatism, you can put two powers in a lens, a vertical power and a horizontal power. If you have irregular astigmatism, you actually have 5 or 6 or 7 different powers. And even if you could do that in glasses, which you can now with some of the newer digital technology, every time your eye moves, now you're looking through a different power. So you really need a contact lens for irregular astigmatism so that the lens moves with your eye. So this is regular astigmatism, and this is the topography. So you remember the other topography where the whole thing was green. So this is a topography of regular astigmatism. The red is steeper, so it's more curved in this direction and less curved in that direction, and it's pretty symmetrical. And so contacts for regular astigmatism, those could be soft lenses with 2 powers in them, and they will always have this small etching here. If you can see, that shows that the lens is oriented correctly. But remember, right when you put the lens on, that could have been in any direction, and then it does take a minute, not long, to settle into the right spot. This is irregular astigmatism. So you can see there's just sort of like a blob of steepening here. So this would be like a mountain peak, the cone shape of the cornea, and then this would be like a big drop off. So each of these colors is a different power. So this is a very, very different power than this, and then in between, there's all sorts of different powers too. So it is, not really possible to get every single power in there. So a hard contact lens then is going to be necessary for this type of eye. A soft contact lens would just drape over that like a tablecloth. It's not going to be able to correct all the powers. A hard contact lens, though, is going to sandwich a thin layer of tears, and the tears are going to fill in all those peaks and valleys. So then you get one new smooth surface, and then you can correct for that power. And here's the slit lamp exam of this patient with keratoconus. You can see this bulge forward, and it's starting to get a little cloudy. So that's where we start having issues correcting these with contact lenses. If it's just irregular, the tears will fill in all of that. But if that cone gets too advanced, then you'll also have scarring at the apex. And a contact lens is not going to be able to fix that part. Then they might need a corneal transplant. So these are some different hard lenses for irregular astigmatism. Gas permeable lenses are smaller, hybrid lenses, and then scleral lens. So gas permeable lenses, the old type of hard lenses, I'm talking about maybe 30 years ago, they did not let any oxygen in, 0 oxygen. It was just actually the very first hard contact lens was a glass lens, actually. So over time, the contact lens materials have improved a lot and let in a lot of oxygen. But because they let in a lot of oxygen, they could let in bacteria and other things too. So that's why you have to be careful not to put water on the lens. But if you can look down here, the hard contact lens is going to sandwich a layer of tears. And so you can see how even if you have a very irregular cornea, all those peaks and valleys will be filled in with that layer of tears. And then you get this new smooth surface, which is going to refract the light properly. So this is a patient with a corneal scar right in the middle. So they're going to have a very irregular cornea just right at that spot. This is with a rigid contact lens on top of it. So you can maybe barely just see the edge of the lens right there. And this is with fluorescein dye. So now it's very easy to see the contact lens because the dye colors the tears. We can see the tear layer underneath, and it's a pretty even tear layer. If we see a big gap in the tear layer, that means that the lens is pressing down too much, and then we would need to get a steeper contact lens to let more tears under there. It is a little bit of a balance because if you get too many tears under there, then the patient's going to get an underwater look and it's going to be less comfortable. And then oxygen also is going to have a hard time getting through that thick layer of tears. That layer of tears does have a power to it as well. So when we change the shape of the lens, for example, if we need to make the lens more curved, we need to change the power as well, because then we have to factor in that we added more of the tear lens power. So hard lenses sometimes are used for myopia control. This is a technology called orthokeratology. It's a purposely flat hard contact lens that does press on the cornea intentionally. So you wear these type of lenses at nighttime. Pressure from your eyelid presses on the lens, which presses on the cornea, and then your cornea molds to that flatter shape. And so you wear it overnight, and then in the morning, you wake up and your cornea is still molded to that shape. You take off the contact and you can see well without a contact. Eventually, over the course of the day, your cornea reverts back to the original curvature, and then you wear it at night again. So there have been quite a few studies that show that this can reduce myopia progression in children and adolescents. I'm not a huge fan of this technology. We don't really do it here at Georgetown just because I find that it wears off before the day is over. And then you're in this like gray area where it's not quite your original prescription. So you can't just go wear your glasses. You're just kind of in between. So some patients like it. We don't do a lot of that here. And then, these hard lenses, they're sitting on your cornea. So you do feel that. It's a hard lens material that's sitting on your cornea, which has a lot of nerves. So many of these patients feel a bit uncomfortable with the lenses. The other big issue with hard lenses that are smaller is that they often go right up to the edge of the lid. So every time you blink, you're sort of hitting the edge of that lens. That's why a scleral lens that's bigger is actually going to be more comfortable, even though the lens is bigger, partly because it tucks up under the lid, and then because it sits on the sclera. But a hybrid lens is trying to solve some of these issues. So it's a hard lens in the center, and then it's a soft lens on the peripheral edge. And so you mostly feel the soft lens, but you still get the correction of a hard lens. I personally don't like these lenses that much because people can feel the transition zone, but some people like them a lot. You can also do a piggyback system. So you wear two lenses. You wear a soft lens with no power, and then you wear a hard lens on top. So you get the vision correction of the hard lens, but you feel the soft lens. So I think that works a little better than the hybrid system, but it's a little bit of a hassle because you have to wear two lenses. Really, if you're having issues with comfort, I would always just suggest a scleral lens. So a scleral lens is just a large diameter gas permeable lens. So it's the same type of hard lens material, it's just bigger. And it vaults over the cornea completely to land on the sclera. And so it does trap a layer of tears under the lens. It's sitting on the sclera entirely. It's not touching the cornea at all. And because it's a large lens, our natural tears are not enough to fill it. So you have to fill up that lens with preservative-free saline before you put it on. Downside of that is you can't put a contact on in the usual way because then all the liquid would spill out. So you have to keep the lens flat and you have to bring your head down to it. It's also a larger lens. So both of those things combined do make these lenses a little bit hard to insert. But once it's in, it's very comfortable because it's sitting on the sclera, which doesn't have many nerves. It's tucked under the eyelids, so you don't feel the edge. And then you get this big liquid tear reservoir that's on your eye the whole day. So these lenses can be very comfortable. This is advanced keratoconus. You can see this slit lamp photo, how the cornea is very bulged forward. And then this is a scleral lens with that fluorescein dye. So the cornea is still bulged forward. We're not pressing that cone in, but the tears are evening out that curve. And so when light hits now, it's just hitting this spherical surface. And so we don't have to worry about all the peaks and valleys that were in that cone. So this is a topography of someone with keratoconus. So again, here's the steep area. So all these are different powers. And then this is also a corneal thickness map. So as that cone grows forward, the tissue is getting stretched out. So patients with keratoconus end up with quite thin corneas too. So this is an anterior OCT. You can see the cornea is steeper and thinner here where the cone is. And then this is also showing the scleral lens and showing the layer of tears in between. And so different scleral lenses have different ideal tear layers. We can measure this and make sure that we have a thick enough layer there. And then we also do have to look closely at the edges, because if the edges are too tight, that's this scenario here, it's digging into the sclera. They may not necessarily feel that, but they're not going to get oxygen cycling under that. And then this is a better fitting edge here. This is a patient with corneal intact inlays. So it's a hard plastic inlay in the cornea. Typically, people have 2 inlays. This patient got hit in the eye and one broke and had to be removed. But now they're going to have a very irregular cornea here because this is going to be a bulge forward, and where they had that other one was a scar. And so they're going to have different curvatures over this versus the other part. And then the reason that they're having the intact is to try to stabilize the cornea to prevent further progression of keratoconus. So here's a scleral lens. On top of that, the lens, the tear layer, this is the cross-section of the intact. And so we don't really need to factor in how irregular the cornea is. We just get that new curve from the scleral lens. This is a patient with a corneal transplant. You can maybe see the edge of the graft here. So you don't have to have a scleral lens for that. You can have a very large diameter rigid lens, but it does have to be bigger than the size of the transplant, because the grafted cornea is a very different curvature than the peripheral original cornea. So once you get a big lens on there, that's going to be pretty uncomfortable. So at that point, you should just go a little larger onto the sclera. And so here's the edge of the scleral lens there. This is an old refractive surgery that was popular in the 80s. It's called radial keratotomy. It involves these radial incisions, and that allows the cornea to sort of like fall in on itself and flatten the cornea. Over time, the cornea kept flattening and in irregular ways. So almost all patients that have had this have to eventually have scleral contact lenses because of how irregular their cornea ends up. Here's a topography of that. You can see how very irregular it is. There's areas of steepening and valleys, and the thickness is kind of all over the place too. So this is a scleral lens on that eye. And this is a picture of post-LASIK. So LASIK is, more common, modern refractive surgery. You could have this with PRK too, which is simplifying things, but it's essentially LASIK without cutting a flap in the cornea. But when you do these types of refractive surgeries, using a laser to thin the cornea and reshape it, and if the cornea gets too thin, then the cornea can bulge forward. So it's essentially like a pseudo keratoconus, where that cornea becomes thin and bulges forward. In this case, it did have some corneal scarring here. Luckily, it's a little bit off center, so the patient can still see through this pupil. But because of this irregularity, they're not going to see well with glasses. They're not going to see well with soft contact lenses. They do need a hard contact lens to get that curvature back to one that we can correct. Okay, so we talked a lot about how scleral lenses can help with these irregular corneas, but they can also help with severe dry eye because they are holding that reservoir of tears on the cornea the whole day. So you fill that lens up with preservative-free saline, and that part is important. It does have to be preservative-free. So it's not just like regular contact solution or regular artificial tears. It's preservative-free, which will come in individual dose vials. So you use one and then you toss it and use a new one the next day. So this is good for conditions like Bell's palsy or thyroid eye disease. What we're seeing here, these 2 pictures, when these patients close their eye, they don't have complete eyelid closure. So they all have some exposure there, which is going to cause some severe dryness. So having a scleral lens will just keep that reservoir of tears on the eye the whole day. So there's a number of systemic conditions that can cause pretty severe dryness. There's a lot of medications that can also cause dryness too. So this is not an exhaustive list, but these are some common ones. Sjogren's syndrome specifically can cause, significant dryness. And so here are some tests that we do for that. Fluorescein dye staining is this top picture here. So we put that dye in, it colors the tears, and the tears settle into the dry spots. And so that's all these little spots that you're seeing here. Each of those spots is an area where the dye has settled because the corneal epithelium has degraded due to the dryness. Lissamine green, that's another dye that stains the conjunctival area a little better. So you can see all the dry spots on the conjunctiva. And there's actually a scoring system here that we can calculate to determine sort of how dry the patient is. And then a scleral lens. This is a slit lamp picture, so you can see the front and the back surface of the lens. And then you can see the sandwiched layer of tears there that will stay on throughout the day. And then this is the cornea here. So this is not an irregular cornea. The cornea itself is fine. This is a scleral lens that's used just to keep the tears on the eye. So photophobia is extreme sensitivity to light. So that can come from dry eye, but that can come from other conditions too. It can come from genetic conditions, developmental conditions. This picture is an iris coloboma, where the iris neural tube did not close during development. And so they have this type of pupil that will never completely constrict to let less light in. Normally, when we look at a bright light, the pupil gets smaller to let less light in. This is not going to happen in this case. So this patient is going to be very sensitive to lights. Other cases might be ocular albinism. There's some other conditions that would cause sensitivity to light, including migraines, post-concussive syndrome. We have a neuro-ophthalmologist, Dr. Ben Osborne. He often recommends specific tint in glasses to help with photophobia for migraines, but you can get that tint in contact lenses as well. So there's a very specific tint called FL41, which is this like reddish tint that has been shown to help with light sensitivity in migraines. And if a patient, for whatever reason, can't or doesn't want to wear glasses, you can get a custom contact lens with that tint. You can also get contact lenses with just sunglass tints. So essentially just sunglasses in a contact lens. And then this is kind of a newer technology, photochromic lenses. You probably have heard of transition glasses. Transitions is a brand name, but photochromic is the technology where when you go outside, the light turns the lens dark. So it's been available in glasses for a long time. It is now available in contact lenses. So when you go outside, your contact turns darker, and you come back inside, your contact gets lighter again. So that helps prevent sort of the shock of going out into a bright light. Sometimes that's the issue for patients that are extremely light sensitive, is just the change between a dark room and a bright room. And so this lens will just transition easily between those. It is like a bit of a weird look if you have very light colored eyes. The lens is dark and it does sort of look a bit odd sometimes, but they work very well. And these are actually not expensive. They're only maybe $10 or $15 per lens. And then you can get a number of custom tints for sports. So these were popular for a while, and then they got banned by a lot of major sports leagues, but you can sort of see like a red tint here on this patient. And different tints can be used for different things. So like a yellowish orange tint is good for fast moving sports, good for lower light conditions. Bluer tints are good for tracking, so like tennis, golf too. Browner tints are good for outside conditions, and then greenish tints are good for glare. So water sports, snow, that kind of thing can be really useful in a contact lens, because contact sports are one time where you don't necessarily want to wear glasses. Now, soft contact lenses are fine to wear for a lot of these sports conditions. Hard contact lenses, you have to be careful. If you get pushed or hit or elbowed in the eye, a hard contact lens can break in the eye. So if a patient needs one of the hard lenses that we mentioned, we always recommend protective goggles when they're doing any of these kind of activities. And you can tint hard lenses as well as soft lenses. And then last thing we'll talk about is prosthetic contact lenses. So prosthetic contact lenses are opaque lenses. So all of these tinted lenses, they're still transparent. You can see the eye through it, and you can see through it. There are certain cases where you might want to block the eye completely. So this is an opaque lens with a pupil, usually, where you can see through the pupil. An occluder lens would be the pupil would be blacked out as well. And so there are certain scenarios where you might want that. And you can get a number of different custom colors. Usually you pick the underprint and then a printing on top for the iris, and you can pick different, accessory prints to get the right eye color. You can stack all these this is a trial lens set. You can stack them on top of each other and then put it on the patient's eye and try to get the best color match. You can take a photo of the patient, send it to the company, and they'll generate the best color match. So here's some pictures of patients with prosthetic contact lenses. So this top picture here, this is a woman with a complete corneal opacity from an infection. And she can't see through this anyway. So she's getting an occluder lens where the pupil is blacked out as well. And this is a really excellent color match. It almost doesn't look like she even had that scar. This is a patient with a mature cataract. So she can't see through this either. So for whatever reason, this cataract is not being operated on. And so a prosthetic lens will black out. So this is more for cosmetic purposes. And then this is a patient with ocular albinism. So the iris looks pink. It's not pink, actually. It's white, but you can see through it. So you can see the retina behind it, which is pink. So that's why it looks pinkish. But without that pigment, the pigment in your eyes absorb the excess light. So a patient with ocular albinism is going to be extremely sensitive to lights because, one, they don't have pigment in their iris, but two, they don't have pigment in the retina either. So they're going to be extremely sensitive. So they have an opaque lens that, for cosmetic purposes will look more normal, quote unquote normal, but it also blocks the light. And then they have a dark part of the pupil. So this part they can't see through, and then this part they can see through. So a patient with ocular albinism still can see. So you don't want a complete opaque lens. You do need an opening of the pupil, but you want it to be much smaller so that you let less light in overall. So that's kind of an overview here. I think a lot of these medically necessary lenses can really be life-changing for patients. They do have to have a pretty precise fitting process. Again, sometimes if the lens is not fit correctly, a patient won't necessarily know it. These are a potential couple of complications. This one here is a corneal ulcer, bacterial infection. And the tricky thing with these lenses is a lot of patients, again, need these lenses. So, if you're just wearing contacts, because you don't want to wear glasses, if something doesn't feel right, then you'll take out your contact and you'll switch to glasses. With these types of lenses, if a patient doesn't feel right, they don't want to take out their contact because they have nothing to switch to, and then they become functionally, essentially blind. And so infection risk is higher with these lenses just because of patient compliance. If something got in their eye or their eye's irritated or they feel the start of an infection, and they keep wearing the lens, that's when we get these advanced conditions. So there's a lot of patient education involved here that even though, it's going to be hard for you to take out the lens and not wear it, if something doesn't feel right, if you take out the lens, the risk of infection is very low. It's usually when people just keep wearing the lens, even though they know something's not right. This other picture here is corneal neovascularization. So this is a patient that's not getting enough oxygen to their cornea. So the blood vessels are trying to grow into the cornea to provide that extra oxygen.